So good morning or good afternoon, depending on where you are located. It's a pleasure for me to welcome you in this new edition of the webinars that aim to provide a space for sharing information, for sharing knowledge about the best practices and the best implementation cases of standards in different hospital processes, and also that provides the possibility of asking questions to the speaker by the end of the session. So first of all, I would like to thank you for your attendance today, and above all, for giving us some of your valuable time. And before I start, I would like to share some details about the organization of this session. Before I begin, I would like to briefly remind you of the antitrust caution, under which all GS1 meetings are conducted in compliance with antitrust laws. So here in the bottom, you can read it by clicking on the link as on the bottom of the slide. And I would like, first of all, to thank Rachael Ellis. Thank you very much for sharing your experience with all of us today. And also would like to thank my colleagues from GS1 UK, and especially our colleague George, for all her support and collaboration to make this possible today. So just a few practical reminders. Please make sure that you identify yourself properly. You can use the rename function, which is on the three dots on the bottom, on the up of your picture, and then you are automatically on mute and your video is off. For any quick message or reaction you may have, please use the raise hand function of Zoom. You can also use the chat to raise your questions, and your questions will be addressed as much as we can during this 1 hour webinar that we have today. So at the end of the webinar, the recording, I'll let you know that the recording will be available on the GS1 website within the healthcare industry section under the heading of healthcare provider webinars. You will find it there. And please take note that all the webinars from previous editions are also available in the same space. So I really encourage you to watch them and also to share them with all your colleagues. So, for those of you who are joining for the first time, I just want to remember that GS1 Healthcare offers these webinars as a unique space for sharing knowledge, best practice, learning, and opinion exchange around three key objectives: to improve patient safety, the most important for, to reduce operational cost, and also to increase productivity. And this through the use of GS1 standards and the implementation of new processes and innovative technologies. So just going very quickly, I also wanted to remind you about the next webinar date so that you can save the date in your calendar, in your agenda. We will provide you with more information soon. It's next month, by the end of next month. And of course, I would also like to mention the largest global meeting point for healthcare sector, which is the GS1 Healthcare Conference, which many of you must know, should know, which is here due to the health issues again. We'll maintain the hybrid format and will be held from the 15th to the 17th of November in Paris. So I'm not going to talk anymore. I hope that the webinar will meet your expectations, and I really encourage you to participate actively at the end of this session by asking questions directly to Rachael. It is important not to ask the questions in an anonymous way so that we can send you the answers just in case we don't have the time during this session. And finally, I would also like to ask you to remember to fill in the evaluation questionnaire that we will send you at the end of the webinar. So nothing else. Thank you very much for your attention today. We hope you enjoy and take advantage of today's session. And that's all. And over to you, Rachael.
Thank you. Thanks, Monica. I really appreciate that intro. I'm going to share some slides. Right, I think, Monica, you might need to stop sharing yours and then I can, there we go. Let's have a look now. Let's see if I can do this, see if we can work the technology. Right, let's see if I can share. Can everybody see the slides? And I'll try and put them into presentation mode. Let's have a look. There we go. Is that working? Give it a second. Is it working? Can you see it on a single slide?
Yes.
Brilliant. Okay, grand. So let's just have a look. So basically, I'm going to talk about scan for safety across the patient pathway and what that means and what that actually does in an everyday setting of the hospital. So I'm Rachael Ellis. I'm the Scan for Safety Programme Director at Hull University Teaching Hospital. I'm not going to talk very much about the hospital at all. It's a very large hospital. It's a teaching hospital across 2 sites. We have around 1,300 beds. We cover every specialty. We have about 11,000 staff, so it's a big hospital, big major trauma centre. So we have lots of different pathways to select. And ultimately, today we're going to cover the following points. So we're going to talk about what is a patient pathway, what does that look like? I'm going to have some kind of demonstrations and some pictures around that. I'm going to talk you through some of the pathways that we have already covered. I'm going to talk you through about how do we actually scan through those, what do we scan, how do we scan, and also about the risk and the highest risk that's prevalent to patients. So why would you bother, basically, compared to other sites? Why would you bother? And then we're going to talk a little bit about how the data standards help you within those processes at each point to make sure that you're leveraging the same information, but also the information is interoperable. You can exchange it within different mediums. So I'm going to talk through some of them today. If you've got questions, I know that the chat box is open to you, so feel free to add all your questions in. Not a problem at all. I'll see how many I can get through. So, I suppose really the immediate question everybody asks me is, why did we do the patient pathway? And for me, it's kind of a really simple answer, which is, I don't understand why you wouldn't, which sounds quite glib, and I understand that. But what I mean by that is about half of all our patients follow a surgical route to a surgical theatre. They have the operation, the procedure done, they perhaps go into recovery or ICU, and eventually they're discharged. But what about the other half? What about the other half of your patients that don't follow a surgical route, that don't, that maybe aren't fit enough for surgery, or that don't qualify for surgery, or actually surgery is just not the best route for them as a patient? What do we do about them? Are we saying that we don't want to scan those patients because they're not important? Well, I don't think so. And that's why, for me, if it's a patient safety programme, which is what Scan for Safety is in the UK, it should follow the patient. And therefore, it should follow at the heart of all the decision making, the patient pathway, because you need to follow where the patient's going. So we look at that. I took this to my board and said, this is the way that we are going to do this. They agreed. And as a result, we have implemented by patient pathway. That's the way that we work. So the actual approach that we took, I went to see in the UK, we have 6 demonstration sites who were funded by the Department of Health to actually set up and effectively set the rule book about how to do Scan for Safety. So I went to see all 6 demo sites. Hull is not a demo site. We weren't given any funding to do this. So I went and looked at it, and there were some really good bits on every part of it. But for me, the part that was always missing is, so when you leave theatre, then what happens? Oh, well, we don't scan anymore. We don't scan on the ward, or we don't scan, when they've gone to recovery or they've gone to ICU. And every time I said why, well, we just don't. There was no real answer. There was no real reasoning that resonated with me from a patient safety perspective. So I thought, okay. So I kept taking the notes and going to visit more sites. But ultimately, then I developed the patient pathway approach, and I'm going to talk about what that looks like a little bit further on in the webinar. But ultimately, you cannot do this without support from staff. That has to be the approach. You have to ask for the help, and you have to get it. But we also wanted to know, what does it cost to go for the patient pathway? Does that make a difference if you choose one pathway versus another? And if you don't cost it all and scan it all, you don't know. So you have no comparable to look at in actual people that are being done, because as we know, everybody has a slightly different journey. Even if they have, the right hip replaced, actually they might have a different recovery. They might have more drugs, more time, less time. So actually it's based on real people, not on a modelling system. And this is where it really comes into its own, because it's real. It's about real people, it's about real patients, and it's about real care. And that matters. So that for us is what we looked at. So we have full cost visible for, obviously, for the staff, for the products, because you have to base it on the 4 Ps. You have to say what you've done, where you've done it, how you've done it, and with what. And we have a really small but perfectly formed team. There's 4 of them in my team for Scan for Safety, and a further 6 at the moment for RFID. And ultimately, it works really well with designated roles. So that was the original approach that we took. And this is a patient pathway. So this is my first implementation. This is where we went live in all of those parts. So we set up with sterile services. So some of you may know it as a central kind of decontamination unit or a sterilisation unit. But ultimately, we wanted to be able to scan every tray that was used in theatre. So every tray, regardless of which it was. So if you're doing a cardiac bypass operation and you've got, an aortic valve tray that you've opened up for whatever reason, we know that you've opened it. We know that that's happened. So we then obviously, we scan in the surgical admissions lounge. We go on to perfusion, which is your cardiac bypass. The patient obviously is anaesthetised most of the time with general anaesthetic, sometimes with local, but mostly general. And then obviously they have the surgery. So that red piece there from a surgical pathway falls out, and it will become replaced by neurosurgery, or it will become replaced by orthopedics or whatever surgery that happens to be. And then ICU, so intensive care units. So this is poorly patients afterwards receiving one-to-one care. And then discharge. Now, everybody finds this a little odd, I think, but we scan the discharge. So we know when patients went home or when they went to a care setting, or on occasion when they went to mortuary. Because if you don't scan, you don't know the end of that patient's journey. You don't know when that is until you actually start to understand what has happened to that patient. So this is an entire pathway. This is the cardiac thoracic pathway that we went live with first. And this took about 8 months to plan out across all of these areas. And then we basically set out, and we started late August 2018 for sterile services. And by January 2019, we were live in ICU. So it was about 12 weeks for all of those areas to go live, to receive their training, for everybody to understand what they were scanning and where and why. And my team worked incredibly hard to make that happen. So that to us is a pathway. And obviously there are lots of pathways. So you need to map out. And this is not, for example, if a patient falls out of bed and, breaks their leg, then that's not part of the original pathway, because that's not the designated plan. We scan to what we plan to do to the patient within a pathway. So that's kind of how it works. And that is how we effectively start the pathway. So the next question then is, where does the pathway start and end? Which is a really good question. And for us, I said, okay, we kind of, does it start here? Does it end there? Shall we end it there? What about this? Do we include that? There was lots of different questions to start with. And I thought, right, we need a model for this. So I developed what's known as the 3 Cs. So the pathway for us internally is based on the 3 Cs, which is it connected to that patient? Is it a patient issue, or is it a staffing issue? So if it's a staffing issue, we don't scan it. If it's a patient issue, we do scan it. So if it's connected to the patient, we scan it. If it's continuous, so if from recovery, they perhaps go to a ward, then that is a continuous cycle. Okay, so the recovery will be scanned, the ward will be scanned. Okay, and if it's complete, so start to finish, where's the planned start? Where's the planned finish? And that makes a complete pathway. And once you start to write those out, you will find that quite a lot of the parts, like for example in sterile trays, regardless of which surgery you go to, because you're already live in sterile services, that part's done. That part you can turn green and say, I'm already done with that. It's connected to the patient, it's continuous, but it also makes it complete. So when you come to roll out in other areas, that part will be done. So that's how it works for us at Hull. And I think it's really, really important to kind of understand that every pathway is different, but we talk to the clinicians and understand where that starts and where that ends. okay? And that's the part. So if they have to have an MDT before being discharged from the hospital, that will be scanned because it's connected to the patient. So those are the kind of things that you need to talk about and consider when you're looking at your clinical requirements for a patient pathway. So there's 6 benefits of implementing across the patient pathway, and there's multiple benefits really for different people. So some nursing staff have massive benefit of understanding the throughput within their areas, of understanding where their staff have spent most of their time this week, this month, today, etc. But ultimately, the 6 that I've listed here are, we've got traceability throughout their hospital stay. So we know what happened to that patient, so we can talk to the patient about it. And also, for example, if we fit, I don't know, an aortic valve today in a patient, in 5 years' time, if they need an MRI, we can look on the system and say, oh, we can see which valve it is. Is it compatible with an MRI scan or not? Because the data's there. You can see it really clearly and really understand it. We can see that patient journey. So it makes it really easy to understand. You literally, type in the patient's details and it brings up everything that's connected to them, which is great news for a clinician because they can see it at ease without having to trawl through, bring back medical records to understand some of the other parts of it. It's great. So it's really simple to use. We've also got visibility. So we've had a case a couple of years ago now of TB at the hospital, and we needed to know quite quickly. There were no symptoms on the patient realistically when they were brought into hospital, but clearly they were already suffering at that point, but the symptoms became prevalent during their hospital stay. But we could say within minutes who'd had contact with that patient really quickly from both a nursing perspective and a clinical perspective. And we'd also done things like on this particular patient, we'd also, it was an ICU case, so it's an intensive care unit where the treatment is very specific on a one-to-one basis with a patient. And we could tell very quickly what else had happened. So we could see when they were hydrated and by whom. So we knew that one of our unregistered nurses, that help out with a lot of the caring, actually they had contact with this patient. So we could get everybody tested to say, you need to be tested potentially because this is a TB patient. So when you do have contagious infections, etc., you've got full traceability because you know which members of staff was with them at what point, which again, during COVID came into its own. It had big benefits there too. The next one is around the sterile trays and instruments. Clearly, we can track them to every patient, and obviously they are recycled. They are washed, they are sterilised, they are cleansed, and then they're reused. So if we have a patient from, oh goodness, I don't know, 5 years ago that unfortunately contracts new variant CJD, then actually we can then see what hospital trays were used if they had neurosurgery, for example, which is quite high risk surgery for new variant CJD. Then we can look at that and then say, who else has used them trays since then? And that is a couple of minutes of searching. It doesn't take very long at all. And I would ask you to consider in your current status, can you do that? Can you do that at your hospital? Because if you can't, it's a major driver for patient safety. If we do find cases coming through like that, then we can actually track all the sterile trays. We've got product recalls. Obviously, we have them quite regularly across different manufacturers, across different products, and they're really quickly to use. We had one quite famously during COVID, where we had a ventilator recall, and we knew exactly which ventilators were on which patients because we scanned the assets to the patient, and we knew which bed they were in because they were on wards that were already live. ICU is live, lung function is live, and home ventilation is live too. So we knew exactly, and within 39 minutes we had a full handle quarantine and had written out reports and data to everybody that was involved saying, these are your patients, do you want to go and check them, do you believe they're at risk, etc. So that was incredibly powerful, using the system without any nursing intervention at all. So that was it was incredibly beneficial, but it was also very reassuring to every patient, because we had quite a lot of inquiries about it. People had seen the recall on the news. We were getting a few inquiries. So our comms team, that obviously, you know, and the patient liaison office could put together saying, this is what's happened. We've managed to do the recall. We've found every ventilator that's affected. We found it in less than 40 minutes, and we've quarantined these, and we've put them, you know, to one side so that the software can be updated. Incredibly powerful, incredibly powerful. For expired products, you get a scan in live time. So it will actually say to you, this product's expired. It will also tell you if it's out of date. So you can actually see the detail, and that's on both sterile trays and also on product itself. So sterile trays only have a life of just less than a year from the date that they were washed and cleansed. And products generally have between 18 and 24 months as a general rule. We can also extract a lot of the data. We are required in the UK to do fairly extensive data and analytics to a subsidiary of the NHS called NHS Digital, which we have to do on a mandated basis, and we have to provide extremely detailed levels of information regarding lots and lots of detail around the implant, around the data connected to it, the serial codes, the lot, the batch, etc. And it all has to be sent to them in a really timely manner. And by having Scan for Safety in place, we are compliant to that. We can do a great deal automated, which is marvellous. So it saves everybody quite a lot of time. I talked about the ventilator recall. So these are some of the real life benefits. You know, we took 38 minutes to identify it. Absolutely fantastic. Really, really fantastic. We were delighted by it. It was 100% too, because we knew that if we had that ventilator and it was being used, it was in the system. So we were really comfortable and confident that what we'd done was correct. We've also used it with patient queries. We've talked about some of the other bits and pieces, but queries from patients. Some patients want to know what's happened to them. Which nurse did this? How long did it take? How long, how much did it cost for my surgery? They're interested, they want to know. And actually, we can tell them that almost to the penny. We can say, this is what we have scanned against your care, if you're interested. Now, obviously, it's free in the UK, is healthcare at the point of care, but people are interested. People want to know. And they also want to know odd things as well about, what type of hip did I have and what serial number is it? Because they sometimes want to track them themselves. So we do get patient queries as well. And again, we don't have to pull records back. We can look on the system. We can actually just look up the detail and say, this is how it's all going to be. We talked about the TB alert. We did have a positive TB alert, tuberculosis, and basically it meant that all the staff could be effectively ring fenced, and we could say to the staff, this has happened, you've been in contact with an infected person, and we therefore need to talk to you about what to do next. But we could do that, and they were identified in theatres, in recovery and anaesthetics and ICU, and that was all done within about an hour of recognising that we had a positive TB result. So we were told, we pulled the data, we sent it out, and very quickly we were able to identify everybody. Most people were still on shift. That's how quick it was. And again, I would ask you whether or not you can do that from a patient safety perspective. But it could have been the opposite way around. It could have been a member of staff that had TB. It wasn't in this case, but it could have been. And we would have then said, where's that staff member been? Because you can do it the opposite way around, of course. You can track it by patient, but you can also track it by staff. You can say, what patients has that staff member had interaction with this morning or today or yesterday? We can do that too. So it makes it really good for, kind of contact traceability for infection prevention and control. So what does it look like? So when we get a recall, and it looks very much like the one that you're looking on screen, you get a list of numbers, you basically, you just get a big, it's often like a really big level of detail, and they kind of go, this is what's been recalled, and you go, fantastic, okay. And then what we then do is, we used to, the middle picture there is the implant books, and we would literally start opening the book and flicking through page by page by page by page, depending on what we needed to find and how quickly. Sometimes we were given a date range and sometimes we weren't. If you're not given a date range, it makes it a really tricky task. But now we literally, plug it into the system. We say, right, okay, if it's this serial number that the red arrow is pointing at, who's had that serial number? And we can then check it. Yeah, we can see it's being used. This is an excerpt. It's not the exact detail because it contains patient data, but we can see that that was used, and we can see what date, we can see the expiry date of it. This is one from a few months ago now. You know, in fact, I think it was about January last year. So we can see all the detail on it and understand where it's all at. And that's incredibly powerful, because then you can literally just punch in the numbers that you've got and work out, A, have you got any on the shelf? B, have you given any to a patient? C, have you got any that, you know, kind of you might have floating about in other storerooms, etc. But also, when that happens, you get, it looks like this. This is how it looks on screen. So what happens is you get an alert in real time. So if, for example, they picked that item yesterday because it's going to be used today, and it's already gone to theatres, you can't stop it. It's been picked from the storeroom. It's no longer in the storeroom. It's going to the theatres. They're wheeling the patient in. They come to scan it, and it says, no, this now either expired, or you get the same for one which has for actually been recalled. So that's the kind of safety messages that it gives you, and those are the kind of things that are absolutely invaluable, because if you then receive stock from another hospital, you know, perhaps in 3 months' time, it will still produce this kind of message that says this item is on recall, don't use it. So you may never have had any of the stock when the recall came out, but what happens after? What happens if you're really desperate and a rep brings you some stock from the boot or from another hospital, and actually nobody checks that? What happens then? So these stay in the system and are for products are live all the time. So when you scan something, it then becomes how it is. So you see this kind of thing, and it tells you how long ago. You can still, if it's your last one and it's life and limb, you can make the decision if the packaging looks okay and the product looks clean and tidy. You know, if that was a week ago and you don't have another one, the chances are that you are going to use that. You would then continue and give a reason that you are happy, you've checked the packaging, and there's some buttons behind that to do that. So that's what you actually, what it looks like. And we also have some others which are incompatible. So these are based on GTINs. When we set the rules in the system, these are based on GTINs. So if you're doing the one on the left, you can see it's an incorrect product. Yeah, so we can see that actually that is, you know, it's saying the right, but you've scanned the left. So you're doing a right operation on the right hand side of the body, but actually what you've picked up is a left hand side product, and it brings you that up and says this is the wrong product for what you're trying to do, because effectively we create rules in the system based on GTINs. We know the GTINs that are going to be for the right, so we load all them in and say if it's not one of these, please issue a warning, and that's what it does. So on the right hand side of the screen where it says product incompatible, that means that actually probably you've picked one like a male and female that actually are no longer compatible with each other, or you've picked one that doesn't fit with the curvature of the implant that you've got. So that's also another one that we load in by GTIN, so that we know that that's incorrect to what needs to happen. And it's just another fail-safe for, you know, busy staff in a busy theatre, because often the packaging on these items looks the same left and right, you know, male and female, they look the same. So often you will get these and you just pick it up, you're busy, you know, and actually they've worked out, they've picked the wrong size, they need a bigger size, can you go and get it? You rush off, dash off to get it, bring it back, and actually you bring the wrong product. So we can load in rules based on GTINs, and that's really helpful too. These are some of the risks around patient risks. So this is kind of, I suppose, really why we scan certain things. So product risks we've talked about. Product risks is because of recalls, it's because of incorrect product. Process risks is around should something have happened and it hasn't. So if it goes step 1, step 2, step 3, step 4, and there's no step 3, potentially you could, on the process of step 4, say you haven't done step 3, this is an incompatible process. So you could do that too. And I think that's really important, because sometimes you have to do certain things with patients at certain points, depending on the treatment plan that you're actually planning to do. So again, that's one of the things that, you know, it is a risk, and it eliminates some of those risks too. Contact risks we talked about the TB cases, about also the fact that obviously during COVID we could have traceability traceability. If a patient was negative COVID and then developed COVID, we could also see which members of staff have been in contact with them. Asset risks, these are quite important really, and are often overlooked. People look at product, I think, although I do think assets catching up now, but asset risk can be connected to ventilators, it can be connected to syringe drivers, it can be connected to anything you want it to be. So basically, if you want to know where assets are and which patient had what asset, you can do that. And it's important to kind of scan them. So that's what we do. We actually do all of that piece using GIAIs. We scan home ventilators out, we scan pulse oximeters out, we scan T34, which are end of care palliative care pumps out. So we can do that too. We also scan in the theatres lots and lots of equipment which are used for perfusion, for heater coolers, that kind of stuff. So you can scan whatever you like if it's got the right barcodes on it and you've got the right standards according to those. Some historical risks. So what, as a hospital, are you really bad at? What have you kind of almost keep repeating, unfortunately? Where's the weak point? And that sometimes is because of building layouts, it's because of staffing issues, it's because of service issues. But ultimately, if you know there's risk in there, then I would try and look to scan that as part of your pathway so that you can try and eliminate as much risk as possible. And finally, reporting and data. If you know that you've got a report like what we did for NHS Digital, it didn't make any difference to us. We were already scanning more than enough detail, but we did now have to rename some of the fields so that actually it would match to what NHS Digital had asked us to do. So it is worth looking at what reporting and data do you need to do locally and nationally, but also what do your teams want clinically? What do they want to see? What's their expectation? And that's really helpful when you are looking at a patient pathway. So those are some of the risks that you can cover by scanning throughout the pathway rather than perhaps just scanning in and around theatres. Why do GS standards sort of play a really important role? Well, product GTINs are really, really easy to read by a barcode scanner, and most suppliers understand, you know, the need for GTINs. They get it, and a lot of them now, a lot of packaging does have GTINs on. Not all, but a lot, a vast majority. And products are easily recalled then, and that is the mainstay really of Scan for Safety in the UK. A lot of products were recalled, and we needed to understand it. But also, you can have different product unit of measures with different GTINs. So a pallet will have a different GTIN to box. So if you order by the pallet and break it down in a bulk warehousing type situation, you can still order by GTIN. Whereas if you use them as singles in a theatre, you can still scan the packaging for one. So it's really important. And then for stock management, you can actually have some collaboration with those pieces to understand that that pallet contains 480 of those singles. So you can actually do it for your PAR levels, for your reporting, you can look at all of that. Assets which have got GIAIs, as I talked about, can be recalled in the same manner because although it is a different standard, actually acts in the same way because you're still scanning it to a patient in a location at a certain time by a certain member of staff. So we still have full traceability to it and we can understand how that actually works. And then finally is your GLNs. So the GLNs around the estate can make it easier for you to ensure that you do have the right location and the right sites. If you've got multiple sites, which we do, and also you can then look at exactly where that happened, because just because it always happens in that theatre doesn't mean in 3 weeks' time that it will. You know, we've had occasions where we've had to conduct surgery in ICU. You know, we do have occasions. It's infrequent, but it does happen. And if you don't have the facility to then put in ICU as a location, then actually your data is incorrect. So it makes the data cleaner, but it also means that more people can use that data for different things. You can look at your structuring of, you know, when is theatres the busiest, when are theatres not the busiest. And it sounds really obvious, but actually it's not. Sometimes a Thursday afternoon can be busiest and a Monday afternoon can be the quietest. So there is some trends and patterns that you can actually look at by understanding the locations, and I would urge you to do that. So there is some surprises. We did have some surprises. I was when we first started, I was really I was really, I suppose, apprehensive about how this would go because nobody had done the patient pathway before we did it. And I was really apprehensive about trying to almost sell it because I didn't understand what I was going to get, if I'm honest. We knew what we wanted, but we didn't know when we were going to get it. Now we did get it, and that's great. But I was surprised by the engagement of the clinical colleagues. They really wanted this. They wanted to simplify. They wanted to digitize. They wanted to scan. They were quite happy to scan. I was surprised by quite a lot of the benefits we could see for lots of people, lots of activity happening, some surprising things. I remember, kind of talking to one of, the sister that was on cardiothoracic at the time that then came to join my team in due course. And she said, it takes me 8 hours in a month. The final day of the month is literally spent looking at activity and trying to marry up my finance piece around what I've spent on my orders compared to the activity, and I can never match them. It's dreadful. I can't do it. I said, okay, so what you want to see is you want to see what costings have gone through, what orders you've got on place, what activity you've had. She said, absolutely. That took less than an hour, even on the first attempt that we did. And by the end, it was taking about 45 minutes. So it brought lots and lots of benefits to lots of people, sometimes in quite surprising ways. I was surprised at how flexible we could be and how most items can now be scanned because it's got barcodes on, and I was surprised how automated we could be in such a short time scale. We've got 21 pathways live even with COVID in 4 years. So actually you can really get motoring with this if you have a model, if you have a really clear engagement, and also you have the benefits lined up for all the clinical staff to see. You can implement it really, really well. So there were a few surprises, but actually no major surprises that we were daunted by, that we actually had to stop the programme. So, most good surprises really. So that was most of them. There's a couple of firsts from us, and this is my final slide before we go to questions. So we were the first to develop the patient pathway approach for Scan for Safety, and we were the first to scan in an ICU unit and first to scan to mortuary. But that's because it makes it complete. And if it's right for the patient, then it's right for the programme. And that for me is massive, just massive. We need to understand where the patient is going, and we need to follow that patient, because if it's a patient safety programme, we should be putting patient safety at the heart of the programme. So follow the patient. That would be my view. Clearly, every hospital is different. It's a cultural thing, but it's also a patient pathway thing about, you may only do parts of the pathway, so you may determine to just scan parts of it. But yeah, and finally, we were the first to scan to community patients. We scan quite a lot of equipment to patients who are not in our hospital. They're an outpatient and come for a clinic perhaps once a month, twice a month. So that's what we did. So yeah, we ended up making quite a few firsts because I pushed for wanting a patient pathway approach, and for us at Hull it works brilliantly, and other people who've also attempted it have had really good levels of success. So happy to take any questions. I don't know whether there are any, Monica, I'm not quite sure, but if there are, happy to take them.
Yes, there are indeed, Rachel. So thank you very much for sharing with all of us today this, I will say, amazing project. It's a patient safety project at the end, and you have shared it, let me say, in an extraordinary and clear way to all the attendees today. So congratulations for both things. Now, yes, we have to move on to the question and answer session, and just to break the ice. The first one was Fergal, your colleague from St. James Hospital, Ireland. And the question from Fergal is, when you went to the board, did you have a cost business plan? And also, what anticipated outcomes or benefits did you present? And were they financial, operational, or patient safety?
What a cracking question, Fergal, let me tell you that. So, it's not a politician's answer, but actually, what I took to the board was, I took some scenarios to the board. That's actually what I took. And I said, would you be happy if we didn't scan all the patient pathway? And they sort of went, well, maybe. I said, well, would you be happy not knowing what the full cost is? Oh, no, we want to know the cost. Okay. So I kind of turned it on its head and said, so if you want this and you want this and you want this, then we have to put the patient pathway approach forward. And I also said directly to the chief nurse at the time, are you happy that we don't scan 50% of our patients? Are we not bothered about those 50%? Of course, the answer was no. We are absolutely bothered. So then that pretty much gained buy-in from everybody, because nobody can say that a patient's not important because they're not having surgery. And therefore, that's kind of how I did it. What I also did for benefits was I said, we are going on a slightly pioneering version of Scan for Safety because nobody's done this before, but I am expecting this, this and this. And I was quite clear about, we will have data against all of the pathway. And I actually used the cardiac pathway, that's the slide pretty much that you've seen today, around all of the areas. So I said, I'm expecting to see this, to see this, to see this. And I went and did all my facts and homework about what the stock looks like in those areas, what the risk looked like, what we'd had as reported incidents in those areas, what patients felt were, you know, what complaints were. That was anecdotal evidence that I gained from the clinicians, included all of that, and was prepared for, if I'm honest, you know, kind of a slightly heated discussion, but it wasn't. The heated discussion didn't happen. The board just said, yeah, we agree. We totally agree. We get it. We understand it. You know, let's pilot it in this area. And if it's not working, bring it back. But otherwise, we kind of give you, you know, confirmation to proceed. So that's what happened.
Thank you very much, Rachel. There is another question from Fergal, just to it's regarding the IT systems, or if did you require to purchase a new IT systems or modify the existing ones? And was this included in any business plan?
Yeah, so again, the system was already bought when I arrived, so it was my role purely to do Scan for Safety, and basically when I arrived, the system had already been bought. So I had to work with a system that had never been unboxed, it had never been used, and it was a case of, there's a brand new system, make it work. So that's what we did, and we basically worked on that basis and sort of understood what it could do, how it could do it, and I just challenged it constantly, really, to make it work for us within the setting that I'd kind of promised the board to do.
Okay, thank you, Rachel. There is another question on the chat from John Howells, and he asked, do you scan through the sterilization process?
Do we scan through the sterilisation process? No, we don't. We don't. However, what we do is we scan them into storerooms at the moment, but very shortly, in the next 2 to 3 weeks, we're actually going live with RFID. So the scanning will stop because it will become automated by RFID labels, with passive tags being activated on every trace. So we'll be able to trace them through the system of RFID. So yes, we have been doing, but going forward in the next few weeks, that will actually change.
Another question from Farron. What is the current status and future plans for adding scanning each medication administration event, and what are the barriers that you...
Yeah, it's an interesting one. Pharmacies are really interesting. Pharma and drugs are really, really interesting. They're tantalizingly close, but they're kind of with it, you know, they're on the precipice of the edge, and you've got to really look over and understand it. We've been talking to pharmacy actually very recently, and we have agreed quite recently to go live with them for inventory management. However, there is a caveat to that, because when we first started looking at this about 4.5 years ago, we actually couldn't scan everything because they had barcodes on boxes, but they didn't have barcodes on blisters, you know, the individual tablets of what you've given. So when you pull things out and split boxes, which they unfortunately do, you know, kind of across a busy hospital, or they send drugs with a patient to a ward, then there were nothing to scan. And what we didn't want was manual entry on something as important as drugs. So we've only recently picked that back up again, really because the Falsified Medicines Directive gave that some teeth, to be fair. And as a result, now most things have got really good levels of barcodes and standards on boxes and packaging. So we are going to relook at that, and we will scan drugs to patients, and also within our oncology teams for those that are making up specific prescriptions for patient care for that day.
Thank you, Rachel. And linked to this question, there is another one which I think you have already answered, but the question is if you can also include products like blood, cells, or tissue.
Yeah. So we already do that. We do already do that. So yeah, we already scan when blood's used. We already scan when we do cranial flaps, etc. So we already do quite a lot of that. And if we send product to the bone bank when, you know, things are harvested for bone bank, then we do that as well. So that's already in there, you know, kind of as a procedure, basically, so that we know that we have done that. Yeah, absolutely.
Thank you. A question from Kurt Atardo. Sorry if my pronunciation is not accurate here, but which tool is in place? How do you ensure to have the updated data in your system?
Yeah, basically, if they don't scan it, it won't order it. So it's kind of no scan, no stock. So it's in their interest. If they're going to change their products, they need to tell us, because if they don't scan it, it won't trigger orders. The system triggers orders based on minimum levels, maximum levels, and what's known as a trigger level. So if you don't have all the details in there, it won't place any further orders for you. So it's much easier to place the orders through the system than external to the system. So as a result, the data kind of is perpetually self-cleansed by areas who effectively think, oh, I'm discontinuing that range, but I'm starting this range. So I will, and it's no, internally we have a change process for actually managing that, so that we discontinue. You can flag items for discontinuing the system. So they're going to be discontinued when they get to 0, and we're going to instead create these new range of, I don't know, 12 new products. So they get added and inserted into a location so that we know that they're going to be stored in that place, and each of them have minimums, maximums, and trigger levels added.
Good, crystal clear then. Then we move to the questions from products to the staff. Lindsay Robertson asked you, you mentioned you had 4 people in your Scan for Safety team. What are the roles?
Yeah, and actually, it's a really good question, that. One of the, so there's myself as the director, and I basically lead the team. I look at the strategic piece. I go out and canvas to people, you know, kind of, I talk to people. I understand what's going on around the hospital. I've then got a Scan for Safety specialist nurse. And so she is a qualified nurse. Actually, we've just got a new post opened up through retirement, and Sarah is an anaesthetic nurse by trade, if you like. So she understands theatres completely, and she gets how it all works. So she understands the patient pathways. She can go and talk to other nursing colleagues and say, how does that work? Where do you scan that? Where's the pain? And nurse to nurse works brilliantly. And then we can build that back in. I then have an analyst, and their job really is data, numbers, data sets, understanding patterns and trends, what looks right, what looks wrong, and she can spot something that's wrong in that system from 200 yards. She's quite incredible. So that also helps. And then finally, we have a really important role of a coordinator. And the coordinator is the glue that holds everything together. The coordinator has a role that's really difficult to describe, but if you didn't have her, it wouldn't work. So she organises things, she goes and checks things, she goes and talks to people, she gets products, she does a lot of the product recalls and manages a lot of the piece that goes with that. She also, makes it her business to go and talk to everybody to say, we're coming to your area quite soon. What are your issues? And she goes and talks to all manner of level of staff. So it could be a housekeeper right through to a consultant, and she will talk to all of them and say, what's going on? Now, we do formal workshops and we do have comms, but the glue of the coordinator role is really important because she keeps us on track and she helps us out, and she kind of corrals from the back, she drives it from the back really. So yeah, very important. And everybody within the team understands what role they have to play, and therefore it works really well because we all kind of carve the jobs up and we know what we've got to do.
Thanks. There's a lot of questions, Rachel, on the chat. So
okay. Keep them coming.
Yeah, just the answer, the most questions we can erase. So here is one from Nian Horan. Say, are you using the 2D codes that were added to pharma products as a result of the FMD for this patient pathway process? Or were these codes added for other reasons?
Yeah, so in a nutshell, the answer is that we've got a real mixed bag going on in pharmacy of barcodes. So some are data matrix, some are linear still, but have some of the detailing and have several barcodes to a box. So it is really variable, if I'm really honest. So we're just scoping that out at the moment. And what we will do is we will set protocols. So we will talk to the pharmacists, understand where the pain is, but they will order by that, they will order by the GTINs. So we will create product GTINs and put them onto shelf ends that, for storage, so that they know that that GTIN will trigger product being ordered against that particular set of 36 tablets or of 72 tablets. So we will do that. And we will also create what's known as pocket cards. So pocket cards fit in your pocket, funnily enough. And they're made to fit a nurse's uniform, which also is the same as a scrub's uniform. So regardless where you work, the chances are you're either in a nurse's uniform or equivalent uniform, or you are going to be in scrubs often. So what we do is we create a little pocket card which gives them, usually on two sides, and again the coordinator leverages a lot of this. So we normally have the things that are really important to them. So it might be their top 10 products that they order, and we will put all those barcodes on the back of a pocket card, so they can just literally, as they're going around, order and scan, do what they need to do. And on the front of it is usually a set of instructions just to remind them, this is what you need to scan and this is how to do it. They usually don't keep them for very long, because after a couple of days, most people have got the system. It's a simple system to use, but it is important to actually be able to have that memorizer,
Good. And continue with pharmaceuticals. A question from Eric Tull says, if you scan barcodes on surgery, during surgery, do you scan barcodes on drugs during surgery?
Yeah, at the moment, no, we don't. And I'll tell you why. There's only one reason why, and that is because most fluids that come for surgery they're in a clear bag, and the barcode is linear and therefore doesn't read. It will not scan because they're generally on a clear bag with a black barcode. So currently we don't scan fluids within surgery. That is one of the only things that we don't scan currently, because it's not available. If it was on a white background, we would scan it, but it's not. And what I can't do is have manual entry to a system where we could introduce risk. I would rather not have them, and they remain recorded in the manner that they are already, which is within patient records.
Thank you, Rachel. There is a question here linked, I will say, to sustainability, and I don't know if you can answer this, but the question is, do you have any estimate on how much you have reduced waste of materials?
Yeah, we do. So we know that when we went live in certain areas, there's a couple of definitions of waste, which sounds a bit odd. One is waste that no longer is wasted. So we know, for example, we know in theatres, we hear surgeons shout out, I'm sure they know that we're coming, but we hear them shout out in theatres, don't open that. I might not need it. I don't want them scan for safety team on me about I've not used something, etc. So we hear that. So we don't have any more just in case openings, just open that just in case. They don't. They put it on the side and they wait, which means that we don't have wastage because it's only opened when it's needed. So there's wastage in that element. There's also kind of improved management, which reduce wastage, which is around expiry dates and managing those expiry dates, because we have visibility to up to 12 months out. So we can see what's going to expire when, and therefore we can better manage it. However, we do still have waste, and especially with COVID, because activity obviously has been affected, everybody has been the same. But it does mean that we can actually look at that. Now, we know in areas what they generally declare as being thrown away or wasted each year, and in every area we've either done one of two things. We've either found a value of stock that they were never counting in the first place, because everything has to be in the system in order to be placed for order, so we all of a sudden have a much more complete view of what is on the shelves. And secondly, we talk to them about what wastage looks like, because we can compare procedures, we can compare days of the week, we can compare surgeons, or we can compare outcomes. So we can talk to them about all of those pieces as business managers, as actual consultants, to actually understand what their colleagues are using versus what they're using, and that also helps to drive wastage down.
Good. So a question from Andy Lee. Given your experience with technology, how can it be used, and what do you see as next steps? What from your opinion would be the next area of improvement?
Yeah, and it's a really good question, actually, Andy. So, so basically, I think for us, we're moving towards an RFID-based solution, which is really important because it effectively automates a lot of the. You no longer have to scan. You know, you walk under a reader, and it will read the barcodes and the tags within the chip. So that's quite good, and you can actually look at all that detail. So for us, RFID is the future, most definitely. As a hospital, we've implemented a new system for that. But in terms of the scan for safety piece, I think that you know, there's been various calls from the last few weeks actually in the UK, and it would appear that Scan for Safety is going to have a massive kind of boost for marketing, and they're going to absolutely look at this because they're now recognizing that the sites that can provide really good data also are Scan for Safety sites, because the data is digitized. The data is not at all by any means has got any risk in it. If it's on the barcode and you scanned it, it's the right thing. So that in itself is a major turning point, I think, for people understanding that actually we can digitize these pieces and we can reduce the risk to patients, and that's a really good thing. So for us, we're going to continue on our Scan for Safety journey till we complete. But yeah, going forward for us, RFID plays a part to that too.
Good. So unfortunately, we have no time for more questions, but there are some questions still on the chat. So may I ask you, Rachael, if you have the time to answer if we send to you those questions? And
of course,
that we'll really appreciate this. So for all the ones that have put some questions on the chat, we will provide you with the answers as soon as Rachael has the time to answer it. So thank you very much for your excellent, I would say, and clear presentation of your extraordinary project regarding patient safety. This is really a champion project, let me say this, and for sharing with everyone today, and your extraordinary work as well. So nothing else on my part. Really, thank you all of you for attending today, for attending Rachael's project, which is really interesting, as I said, and I look forward to seeing you in the next meeting by the end of June. So
great.
Thank you all.
Thank you.
Have a great day.
Thank you.
Bye.
Bye.